Hello again, my name's D. Campbell and welcome to a quick video. This one's going to be a little bit tongue-in-cheek because I call it swear words and charting. This is going to be about the words that you have to avoid in your records as much as possible. So don't be swearing in your charts, y'all. Let's start out here with the uncertain guidelines. The big issue with the uncertain guidelines is a lot of people are uncertain about which uncertain guideline to refer to. The issue is we have 3 different uncertain guidelines and they kind of conflict against each other. Let me move my blob here because the one on the far right is the one we're going to care about the most here. So the confusing part for uncertain guidelines is we have a version for inpatient here on the left side, and then we have the outpatient versions basically for it. What makes it extra confusing is that also a .h for the uncertain for section 2 for the inpatient, and then for section 4 for outpatient guidelines, it's also an H. Basically, my ask is in the next year update, please just remove this one since they're just redundant. These two are like exactly the same pretty much. And then that way it could clear out a lot of these confusion. Let's just make it so there's an uncertain guidelines for inpatient and then an uncertain guidelines for outpatient. So let's read the uncertain guidelines for outpatient. It states, do not code diagnoses documented as probable, suspected, questionable, ruled out, compatible with, consistent with, or working diagnoses, or other similar terms indicating uncertainty. Rather, code the condition to the highest degree of certainty for that encounter visit, such as symptoms, signs, and abnormal test results. I do have a video on sign and symptom coding on this, but let's just talk about the swear words today. So what I mean by the swear words are all of these words here on the left side are words that you should avoid as much as possible in your charting. If you ever finish your record where you say the symptoms are consistent with upper respiratory infection, that's going to make it so your coders cannot actually code upper respiratory infection. Instead, they have to code to the sign or symptoms, which will probably be like the cough or sore throat that made the patient come in for. So avoid words like consistent with. That's a very common one that providers like to use, but technically the guidelines explicitly say to never use consistent with. Now that we're at the point where AI is reviewing a lot of records, it's just getting worse and worse. So you gotta be careful with these language guidelines. So just be aware of these guidelines that you want to use words like these instead here on the side. So I have a few different documentation examples of how this would work out. Let's say if we write patient presents, here, let me move my blob to the bottom. Oh, moved the wrong one. So let's say patient presents with cough, fever, and shortness of breath. Possible pneumonia, chest x-ray ordered. It cannot be coded with the pneumonia. Instead, it's just going to be the cough code, the fever code, and the shortness of breath code. I guess that should be RO5.1 though, as acute cough. Patient complaining of burning with urination and urination frequency. Suspect a urinary tract infection. No bueno, we can't code that UTI. Instead, we have to code dysuria and frequency. Patient presents with severe right lower quadrant abdominal pain and nausea. Rule out appendicitis. We cannot code the appendicitis. Instead, we're just going to be coding the pain. Patient presents with headache, nausea, and sensitivity to light. Possible migraines. We'll evaluate further. Cannot code the migraine because it's only probable. Instead, it'll be the headache and the nausea codes. I think you're starting to get the hint of this. Patient reports numbness and tingling of the right hand, worse at night, possible carpal tunnel. We're not going to be able to code the carpal tunnel. Instead, it's just going to be the numbness codes. So let's look at this on the flip side. Let's say we had better documentation. Patient presents with cough, fever, and shortness of breath. Chest x-ray reviewed. Assessment, pneumonia. Bam, we can code for it. Patient has increased shortness of breathing, bilateral leg swelling, evaluation supports heart failure, assessment heart failure. So basically, if the provider is clearly writing out what you think it is in definitive language, then we can code it. Patient presents with severe right lower quadrant abdominal pain and nausea. CT findings are consistent with acute appendicitis. So now we can actually code the appendicitis for that one. So finally, I got just a little comparison here for a few that we can look at together. Patient has increasing shortness of breath, bilateral leg swelling, suspect new onset of congestive heart failure. It's just suspect, so we're stuck with just the signs or symptoms and the localized edema. Patient presents with increasing shortness of breath, bilateral lower extremity edema. Clinical examinations and cardiac testing supports a diagnosis of congestive heart failure. Wham bam, we can code for it. Patient presents with tremors and increasing problems with their balance, possible Parkinson's. We're just stuck with tremors and gait codes. Patient presents with tremors and increasing problems with balance, assessment Parkinson's. Wham bam, we can code the Parkinson's. Patient presents with dizziness and nausea, possible vertigo. We'll monitor and consider. Stuck with just dizziness and nausea. But instead we write patient presents with dizziness and nausea associated with spinning sensation and worsening with positional changes. Examination findings supports peripheral vertigo. Wow, we can code the better code. And that's basically it. I think we're all getting the routine of this, is just make certain you are writing in the highest language possible, so that way we can code to the highest level possible. Otherwise, if you don't, we're stuck using sign or symptom codes instead. So just remember these words here on the left side, I would take out of your language. Just don't use them when you're charting and whenever you're trying to write a definitive diagnosis. Instead, consider words on the right side here that more clearly state that you know for a fact that this is the case. So just remember, it's silly. I know it's silly. None of us can assume. Instead, we can only code what you definitively write. And obviously, if anyone audits you, they're going to go with the lesser one if they can. My name's D. Campbell. Remember, code and document to the highest level possible, and we can all reduce denials together. Thank you, and have a wonderful day. Bye now.